Hello, my name is Stanley, and today I'll be talking about our scoping review on high-dose buprenorphine initiation in opioid withdrawal, more colloquially known as macrodosing. And so before I begin, I have nothing to declare. And so what's important to know is that every day, 20 Canadians die from opioid-related deaths, a majority of them being young to middle-aged men in Alberta, Ontario, and BC as well. And as we can see from the statistics presented here, it's undeniable that we are currently in an opioid pandemic. Now, how do we help this? Well, buprenorphine is a partial mu opioid agonist that works by occupying those receptors, and it helps by reducing symptoms of opioid withdrawal, reduces opioid cravings, and has been found to reduce mortality in opioid users. One way of initiating this is through macrodosing, which is giving more than 12 milligrams per day. And the reason why we do that is because it's been found that it can't be potentially helpful now that we are in an age of fentanyl and higher potency opioids as well. So our objective was to assess the current literature on the safety and efficacy of high-dose buprenorphine initiation. So we did a scoping review that followed Prisma guidelines. We searched Embase, Medline, PsycInfo, and Cochrane Library as well. We used Covidence for our abstract screening and full text screening as well. And then our extraction and all of those processes were done in pairs, and any conflicts were resolved by a third-party reviewer. This is our inclusion and exclusion criteria. And so, of the 3,514 abstracts we went through, 79 of them went through full text review, leading to 15 for extraction. And in terms of the types of studies that were included, a majority of them were mainly cohort studies and case studies and case series, while only two were RCTs. And eight of the studies were actually published after the 2020s as well. And a majority of them were in the inpatient setting, and a majority of them were also focusing on heroin users, which is an issue that I will address later on. In terms of dosing practices, a majority of them were either 32 milligrams or 24 milligrams. And the highest dose that was ever given in one sitting was 96 milligrams in the Amati study that was done. And like half the studies were either a single dose of a high dose or divided doses throughout the day as well. In terms of outcomes, all the studies reported improvement in their opioid withdrawal symptoms, with 11 of the studies reporting termination of all their symptoms within day one, and that there was no difference found between a 3-day high dose initiation versus a 1 day high dose initiation as well. In terms of safety, there was no fatal or non-fatal respiratory depression, and the most common side effects were precipitated withdrawal and the nausea and vomiting associated with it, as well as hypotension and bradycardia that was solved with oral rehydration, which did not require any ICU or pressors. In terms of the limitations of the current literature, as I mentioned, only two of them were randomized control trials, and one of them was only in men as well. And a majority of these studies had low sample sizes, which made it difficult to establish efficacy and safety and power as well. And a lot of these studies also had various differences in what scales were used, the heterogeneity, and what was reporting in terms of outcomes as well. And like I mentioned earlier, a lot of them were heroin users, which makes it difficult to apply in our age of fentanyl and high potency opioids. So where do we go from here? Well, in order to have better meta-analyses, we need to look at a population that is now like fentanyl populations. We need more rigorous methodology and consensus on what dosing practices that we want to use for macrodosing, as well as standardizing the outcomes to report in order to better conduct meta-analysis and compare macrodosing to traditional treatments or even microdosing and other OATs as well. So, in conclusion, high dose buprenorphine initiation is a viable option. It's relatively safe as well in terms of adverse events, and However, in order to better establish efficacy and safety, we'll need more rigorous studies with more homogenized outcomes that are reported between studies as well. These are my references. I'm happy to answer any questions, and thank you for your time.